Welcome to a Shot in the Arm podcast. I'm Ben Plumley, and we're on the road with the Global Listening Project, again in New York. Our guests today, well, first up is Heidi Larson, co-founder of the Global Listening Project. Hey, Heidi, how are you doing?
Nice to be here.
It's good to see you. And our guest joining us, Heidi, is someone we've wanted on the show for quite a while, Dr. Ashwin Vasan, who is let me get this right, the New York City Health Commissioner. Is that right?
That's correct. Good to be here.
It's great to have you here. So, Ashwin, a kickoff question for you. You became the city's health commissioner just as the first Omicron wave of COVID peaked. What on earth persuaded you to take this job at that time? I mean, that must be one of the worst possible jobs to do.
It's very difficult in the midst of a global pandemic as a public health practitioner to say no when you're asked to serve. And I was lucky that my predecessor, my friend Dave Chokshi, is someone who I respect, and we decided together. I was appointed in December as Omicron was just beginning, but we decided together that we would overlap and work together. So I stayed at City Hall for 9-10 weeks and then took over once Omicron had abated. It's very hard, as I said, to not be called to serve in public health when you're asked. But I think all of us following the pandemic also saw that there may be an end in sight, at least an end to the worst of it, that Omicron represented a new evolution in the virus that said that it was spreading much faster, but also on balance, much less lethal. And it got me thinking about what could I accomplish? What could I do to leave things better off after a historic crisis? How could I lean into my training in public health, in HIV, and in infectious diseases, but also my more recent endeavors in mental health to help the city rebuild itself and to build back its morale and confidence and to improve health by tackling all the other health challenges that went neglected during COVID. So that was really what drew me.
You were sort of instrumental in driving the telehealth components of the city's response. You obviously had the vaccines in your toolkit, and of course the antiretrovirals, the Paxlovids. Were you able to deploy those in an effective way with the community, with the city behind you, or were you, like many others across the country, sort of having to, watch your back and really look at how people are understanding what the science is, what these vaccines, what these treatments might actually mean, the pluses and the minuses?
We learned a lot during the pandemic, during the height of the pandemic, about how to deliver medical countermeasures, let's call them vaccines, treatments, tests, PPE, at scale, while also responding to the very clear data that certain communities, particularly in New York City, communities of color, Black and Latino communities, were being disproportionately impacted. Cases, hospitalizations, deaths were all, in the Omicron wave, 2-to-1 was the Black to white gap. And so the balance has always been, how do we move with speed? How do we move with effectiveness? How do we message to the entire 8.5 million people in New York City to ensure that they're getting the best information possible to make safe and healthy choices, while preferentially and specifically deploying resources, disproportionately in many ways, deploying resources into communities that have been left behind and that are hardest hit. Those are hard-won lessons from the first waves of the pandemic, where we might have been slower than we had hoped. And we learned by building up from the ground up programs like Public Health Corps, which partnered with over 100 small local community health nonprofits and deployed community health workers to be that bridge of trust, to be that bridge of engagement, so that when new medical countermeasures and treatments came online, we had a foundation of trust that we could work on. You mentioned Paxlovid. Paxlovid came online in January of 2022, just as I was starting back in city government. And we worked on in an environment of really constrained supply for an entirely new treatment, which had very little confidence in it. How could we ensure that it was as equitably distributed as possible? And what we decided was there wasn't really going to be a good way to do this with the constrained supply by leaning on any one type of pharmacy or brick and mortar, especially at a time when people were also trying to stay home during Omicron.
Right.
So we developed an innovative partnership with an online pharmacy delivered direct to your doorstep. You could call, get tested, get evaluated for treatment. You could even call based on a home test and get evaluated for treatment and have it delivered to your door within, evaluated by a doctor and delivered to your door within hours, which I think was a pretty big step forward before Paxlovid access became more widespread.
Yeah. I mean, Heidi, does this, what Ashwin is describing, have you seen this approach in other cities, in other settings? What resonates?
Well, I think that the nature of the specific interventions will vary on setting, but I think, Ashwin, what you mentioned, this foundation of trust, and I think what's often, sometimes it's focused on getting the vaccine there or getting X intervention there, getting the drug there. But what you're stressing is so crucial, which is about building the relationship. And I think that was something that during COVID was the places that did well invested in that relationship building as you did. And it was, you can have things, access to these things, but if people don't trust and aren't familiar, and that process you went through, and also the fact that when you say equitably, and sometimes people mix with, equally, in this case, it wasn't equally. You needed to do more to be equitable. The places that needed it more should get more. And communities pay attention to that. And when they feel like you actually care about them, it's a trust builder. And when you come back, and when the drugs are there where you need them, these are all hugely valuable interventions that, it really, it was a powerful force. And it was, the other thing about it is it was more than just getting the drug there. It was a foundational thing for the next whatever. And people will remember that. The world is going to remember there's life before and after COVID, and how they were treated and how they were taken care of is really going to be important moving forward to build on.
We've spoken about the role of the faith communities. One of the things that really stood out to me in New York, you spoke about the Black and Latino communities, but particularly thinking about the African American communities in the city, working with people like Reverend Al Sharpton. He was one of the first folks with a bunch of fellow pastors to get his vaccine very publicly in Harlem. And was that opportunistic, or were you really focused on identifying leaders like that?
I think the foundation of trust is presence, and presence not just in times of urgency or emergency, but presence at all times. So that's one. Two, I think shared experience and shared lived experience is crucial for trust. And then really listening and including people in decision making and hearing what their meaning the community is lifting up in terms of what's most important to them. Folks like Reverend Sharpton and the 100 organizations we partnered with through Public Health Corps are exactly the kinds of organizations that are always there. Yeah. Now, they might not have the resources or the technical capacity, or they certainly don't have a long track record of getting big government contracts. And that was on us as the city to say, how can we open our doors? How can we get the dollars to you where you need capacity with data and training and administration? Where can we support you? But then get out of your way and let you be the voice and the face and the front end of the intervention. Whether it's encouraging people to go get tested, wear PPE, masks, go get vaccinated, and later on get treated. It is government understanding where it needs to lead and where it needs to step back and let others lead. And so I think there was intention, and we're very proud of what we built. But two things. One is that it's not like it got out the door that way.
No.
And as I said, those were hard-won lessons and a lot of pain and a lot of suffering and a lot of lives lost, especially in those first 3 months of the pandemic here in New York City. Around 50% of the overall deaths from COVID in New York City happened in the first 3 months.
Wow.
Two, and I appreciate your note of optimism, Heidi, I think people are forgetting. Public Health Corps and programs like it were funded by massive federal infusions of resources, and now all of that money is gone. We're facing fiscal cliffs, and instead of having a robust national policy conversation around how we fund a sustainable public health infrastructure and what are the elements of that, we are talking about further cuts to the Centers for Disease Control. Yeah. We're talking about the attack on local public health authorities and their neutering of their ability to control.
Well, I wanted us
crises.
To come on to this. You've both mentioned trust, and from very different backgrounds. You, Ashwin, as an infectious disease doc, Heidi, you as an anthropologist, asking the questions: who do people trust? How do you get information through trusted sources? And I wonder if you would reflect, both of you, a little bit on your own experiences, because you've both been very externally focused people. You've led conversations around trust, around information that people need to protect themselves. But in this sort of strange era of pandemics that have been also a pandemic of social media and misinformation, disinformation even, you've both been targeted in different ways. And I guess the question is, how does someone who is communicating public health messages, which again have to be outwardly focused, how do you do that while maintaining a sense of yourself, a sense of your own privacy? How, in this era of personalities, is the message more important than the person giving it?
You turn to me. It's a tough one, right?
Yeah. Yeah, you get the first tough one.
Yeah, it's, there are times where I think there are times where you do need face forward in a way, but there are times where you really do need to step back. And I think the distinction that Ashwin made, knowing when to step up and knowing when to step back, is not one that enough people think about, because it's. And I worked in UNICEF for many years, and there was this whole celebrity, culture that I think right now, sometimes you don't want someone in the headline because it attracts. I mean, there was a whole story recently with Taylor Swift's partner that was promoting the Pfizer vaccine, and how, it took advantage of that highly visible platform And sometimes that's good, and sometimes it makes you prone to attack. And yeah, I think this is where, coming back to, again, what Ashwin was saying about partnering with local and trusted figures, there are times when you have to hand the baton on. And I think it's balancing that. But it's been very tough for scientists. I mean, really, if I'm getting death threats, and I'm, Tony Fauci's a whole other league of threats, and I'm sure you've had threats. It's tough. I mean, you as you mentioned earlier, in public health, sometimes it's almost too much of a kind of evangelist feeling that you want to help people. And then you feel like, I'm trying to help people and they want to kill me,
I know you see public health departments, leaders of public health departments all over the country, finding themselves under the spotlight, and they never anticipated or expected it.
Yeah.
I certainly didn't. I mean, I knew what I was getting into with respect to the state of the discourse. I didn't anticipate the degree to which it would land on my doorstep, literally, with people coming to my home and police details and death threats and restraining orders and all of that. Okay, but back to the issue of trust. I think trust really is built on two separate but related axes. One is community trust, and I think we talked a little bit about that. It's civic, it's inclusive, it's based on credible messengers, it's right-sizing the role of institutional leaders in this external-facing presence, or simply handing the baton to a different kind of institutional presence. One of the most credible messengers in Harlem, obviously a historically black neighborhood in New York City, was Melba, the owner of Melba's Diner, right? The famous business owner.
Yeah.
Incredibly credible messenger, and actually served on our COVID recovery task force last year. So understanding those opportunities and really mapping them and using them, and government really saying, how can we be helpful? How can we resource it so that we are not, whatever externalities of our brand and people's sense of institutional trust with government or with any large institution, research, academic, clinical, that we're not getting in the way of that, one. But I think, two, is the axis of structure of institutional trust, and to the extent that external messengers like myself are the faces of institutions. We have a lot to learn, I think, in public health and public policy about communicating complexity and communicating honestly about what we know and what we don't know in a rapidly changing environment. And public health has a history of constraining and restraining communications until clarity is found. And I understand the responsibility from which that derives, that no one wants to share imperfect or inaccurate scientific information when it's life and death. But in an emergency, when there is a vacuum of information and fear and misinformation is filling that vacuum, it's essential that public officials and institutional leaders are communicating early, often, and honestly about this is what we know today, and it could change tomorrow, and we need to and rinse and repeat and rinse and repeat.
Yeah,
if we don't learn that, then as a society and as a field, we will be here again.
And I think that is the big lesson for the public health field, because if there was a mistake, I think that we all made at the start of the pandemic, it was feeding into this sense of, we're the experts, you can trust us. But then as the information changed, as the science evolved, we said, and now do this. And where I live in the greater San Francisco area, the issue, of course, was all around masking mandates in school. And, we weren't able to stand up as a discipline, really, and say, look, we don't know all the answers. This is what we know now. it may well change. We'll come back to you. We seemed in sort of really in our DNA not to be able to be comfortable about a trust relationship that could be open and honest about not necessarily having all the information.
Important point is that, and we are making a decision today based on the best information we have today.
Yeah.
And that can explain why, in the retrospectoscope, some of these decisions look less than ideal, but we made the best decisions we could at the time with the information we had and with our sense of where the information might go. And that's the part that is hard, I think, for us to internalize and communicate, and also hard for the public to accept that we don't communicate it, because they think these are static decisions, not dynamic decisions. And in a changing epidemic like we have had, they're decidedly not static.
And a brand new virus. I mean, this is no one. I mean, we actually, there was more anticipation that we would have another influenza type pandemic if we had one. And this one, I mean, not that we did have SARS as another coronavirus, but that didn't go global in the same way. But it was new. So, I mean, I think people are understanding if you explain to them. And I think what you were saying is the importance of just being there, and sometimes I call it bringing people along with the story. See, take people on the journey with you and say, we have a brand new virus. We're learning as we're going. We're going to share what we're learning as we're going and make the decisions we have to make, and bear with us. We're all in the same boat here. And I think the mask thing was, I know it was in multiple countries. I mean, in the UK, there was on, off, and then there was, well, they're just saying off so the healthcare providers get them first. And even if that was the decision, I think one of the things we've heard from in our global listening project is people felt like, we'll do what we need to do, but help us understand why you've made that decision. You know, if you say masking and containing yourself is important, but we have limited amount of masks, we're going to put them, keep them in the hospitals first. And as they become available, it's a respiratory illness, masks do have a value. But it was, I think this, explain to us why you're making that decision. And we'll, I mean, not everybody, but people were pretty understanding about that. But that was one thing that came up quite a bit. We wish they would have explained why they made that rule about schools, about, workplace, about, you can walk the dog once a day and that's it. Or whatever the decision is.
We did what we thought was,
yeah,
what the data told us at the moment, and what we thought was best. Now, you've mentioned SARS and there was MERS, but there's one other pandemic of this era that perhaps is, one of the prime One Health viruses that emerged, and that is HIV. All three of us have had a background in HIV. And of course, New York, some would say San Francisco, of course, was the epicenter of the community response in the United States. How much could we build on that experience from HIV in mounting an effective community-led response to COVID?
Massive. And we saw it during the next unexpected visitor, Mpox. So it was the community leading and partnering with us in government that led to a historic response. We vaccinated over 100,000 people in just a matter of weeks. And if you look at the epidemic curve, it bent quickly. And it was as much to do with vaccination as it was to do with community outreach and education and behavior change. That was led by the community. And we leveraged all of our partnerships and incredible networks that we've built through sexual health programs, LGBTQ serving organizations, MSM serving organizations, all of it built upon activism and engagement and a health justice framework that comes out of the HIV movement.
You mentioned health justice. One of the criticisms that was leveled at us right across the country around the management of Mpox was that we were really good at mobilizing gay white men with health insurance. We were less good at reaching communities that fell outside those parameters. How did you address that in New York?
I think it was incredibly difficult. We got there first. We were the first jurisdiction to start vaccinating people in June, at the end of June of last year. We did so with an extraordinarily constrained supply of vaccine. And sadly, we didn't see that supply really open up until later on. And that has to do with upstream issues at the federal level and supply chain and preparedness around planning for this outbreak, even though we knew it was coming once we had the first cases in Montreal and in, I think, Boston and New York. So, a lot of the well-intended plans are laid to waste in the face of lack of supply. From the beginning, here in New York, we had reserved appointments for zip codes that were in predominantly black and brown neighborhoods. We had reserved doses of vaccine for community groups, community organizations, and providers that predominantly serve black and brown communities. But I agree with the critique from the perspective of we weren't able to see it in the data because we didn't have the supply.
So let's talk preparedness then on a slightly bigger issue. Heidi, you and I are really interested in how cities as microcosms of humanity build resilience. I know that's not a word we like to use anymore, but build preparedness and are ready for the next challenge. What interests you about the New York experience, potentially as something to lift out the innovation that it developed that could be adapted or learned from in other settings?
Well, I think some of the things that have already been mentioned, but just how things are tailored to you can use communities in different ways in cities. And I think that, I know in London, I was in London at the beginning of the pandemic, and it was interesting that you mentioned the diner in New York, up in Harlem. In London, it was in the Bangladeshi community, we had the highest rate of mortality, and it was restaurant owners who totally caught us off guard doing selfies with them getting vaccinated. But what I loved was the way they pitched it. It wasn't just get your jab to prevent, because our community is getting the hardest hit. It was for that, but then it was also to get business back, and the role of restaurant, especially in urban areas where you live in small spaces, there is incredibly valuable social space. And a lot of these extended families, when they get together, they don't do it at home. So the restaurants were not exactly a church, but a gathering, a social space. So they brought in different messages that we might not have thought about in terms of why you need to get vaccinated. But it's a bit off-piste from your question, but
that's never stopped you in the past. So.
Yes. But I've lived in New York over the years. In fact, lived in Harlem, and even though I'm not living here now, but I just find that there's an energy and a coherence in some of these neighborhoods that you can really build on. And I loved what you said, Ashwin, about history. And we inherit history. And that can be a good thing and it can be a bad thing. In terms of how people historically have been treated, that's something that's sometimes a bit hard to get over. But we can, things like what you talked about, you can renew the memory of history and there can be good historical memory with these kinds of efforts. But I mean, our first big listening efforts at the kickoff of the Global Listening Project were in Sao Paulo, New York, Paris, Abuja, Delhi, and Bangkok, greater metropolitan areas. We thought that with the resources we had, that was the way to capture the most diversity. And it just is a different dynamic. And also why cities are important. You'd think, I mean, historically in international development, it was always reaching the unreached in rural areas, when in fact we see some of the worst vaccination rates in cities. And you think that in a city you have more access to things, but it's not that straightforward. You've got complex dynamics. You've got, I guess the other thing is a characteristic we've seen is that it was in cities that we saw the most acute loneliness. And that was another interesting thing, is how people kind of support each other in these,
So final words to you, Ashwin.
I want to hear what Ashwin says about loneliness.
No, exactly. but the point being that cities aren't just places where, in the public imagination, infectious agents can spread rapidly. There are a range of challenges, including mental health, loneliness, but there are also opportunities that these communities have that make cities actually an interesting place to learn about how to build preparedness.
You asked me why I took this job at the time that I did, and in part it was a product of, in addition to almost 20 years of working in public health, was some of my more recent work on mental health and really seeing the impact of social isolation on health and how it's really an unmet need and has such incredible ripple effects on our physical health and on our resilience for any shocks like emergencies or infectious diseases or otherwise. So now scale that from the individual to the society. Our digital transformation as a globe, and as certainly in cities, has atomized us and separated us, even though we may be in very close proximity to one another physically. And then add on top of it a infectious agent that forced us to be physically separated, and it's just a recipe for loneliness. And loneliness as a dynamic measure of really what's more pernicious, which is measurable social isolation. So I think cities hold the key to figuring out how to overcome social isolation in a densely crowded, populated environment where we're actually quite physically close to one another, but how do we bring people back? I mean, we're talking about this in terms of bringing people back to the office, and how do we use those meeting times not as necessarily places where let's get the work done, but actually as intentional places to form community. And if my recent work has taught me anything, the power of community as a therapeutic intervention for mental and physical ailments alike is profound and an underinvested in part of our health infrastructure. So how does that relate to preparedness? It makes us healthier at baseline and more able to withstand shocks to our collective systems, like the next pandemic, which is likely to come in our lifetimes, and any other health emergencies, whether it be climate or otherwise.
What a lovely way to bring this conversation to a close. We're going to be back in New York very regularly, checking in to see how the city and the state is responding. Would love to be able to come back and check in with you and see what your progress is and any observations and recommendations you have for us. But Ashwin, thank you so much. And Heidi, of course, it is always a pleasure and great to partner with you.
Thanks so much. Really appreciate it.
Thank you for having me. And as a phrase I learned in global health, you are most welcome.
Yes.
Oh, I thought you were going to thank us for our leadership.
Yes.
That's
That's another one. Yeah.
Thanks.
Thank you for your leadership.
Thank you so much.
Yeah.
Well, that's it for this episode. Thank you to Ashwin. Thank you to Heidi. Thanks also to our director and producer, Erica Spera of Newsdoc Media. Thanks to Chad Parisman, our New York producer. Our project coordinator is Waisha Raphael. And a final thanks to you. Have a great week and a safe week, everyone.